Hello, everyone.
We can hear you, ma.
Can you see my screen?
Very clearly, ma.
Okay. All right. So, much. All right. How about now?
Better, ma.
Thank you very much. So good evening, everyone. Again, I'm Dr. Ajayi Tejumade, and I'll be taking us on recent guidelines on first trimestral scan. Okay. I want us to know that the essence of coming in to learn about scanning, how to scan, and understanding the basic principles of scanning is ultimately to be able to improve outcome for both the mother and the child. You know, in obstetrics, you're taking care of two people. You're taking care of one that can speak, that's the mother, and then one in utero that cannot even speak. So I want to throw this question open to the house. And if you know the answer, you can unmute yourself and just answer the question before I go into the lecture. So what is the first sonographic evidence of pregnancy? Is there anybody that wants to answer? The first sonographic evidence of pregnancy. Sorry?
Gestational sac.
Gestational sac. Okay, I'm not going to say if the answer is right or wrong. We're going to decide that at the end of this lecture. So let's note the answer, gestational sac. Thank you very much. The second question is, what does ALARA stand for? Anybody wants to give me a response? I know this was mentioned yesterday. ALARA principle, what does it stand for? Anyone can unmute and take the question, please.
As low as reasonably achievable.
As low as reasonably achievable. Okay, thank you very much for the response. We'll know if that is correct at the end of this lecture. All right, thank you. The next one is, what is the cutoff beyond which the crown rump length cannot be used in assessing gestational age for the fetus? Please, anybody? What's that cutoff dimension beyond which you can't use the crown rump length to assess for gestational age in dating a pregnancy? Anybody, please? So I will take that as no response. Moving on, Doppler is routinely indicated in first trimestral scan, yes or no? Anybody can unmute and take this last question, please.
No.
Oh, that was the chorus answer. Okay. All right. Thank you very much. So I move into the lecture. So these are my objectives. At the end of this lecture, my plan is that every one of us should be able to define what a first trimester scan is and the preferred timing for a first trimester scan. You should be able to understand the role of first trimester scan in antenatal care. You should have a guide for performing first trimester scan. You know, when you talk about guidelines, the good book says that my people are destroyed for lack of knowledge. It's not enough to understand your machine. It's not enough to get good images. You must be able to interpret what you're seeing based on standard practice. That's the only way you can improve care for the mother and your unborn child. You must also know how to diagnose failing pregnancy. So note this, at the end of this lecture, you should be able to have answers to all of this. So let's move on. The first trimester ultrasound refers to any scan that is done in pregnancy, starting from the time at which viability can be confirmed. I want us to note that word, viability can be confirmed. And that is, you're seeing either a gestational sac, most importantly, an embryo that has a demonstrable cardiac activity, and the upper limit of a first trimester scan is 13 completed weeks, which is also 13 weeks and 6 days. All right, 13 weeks and 6 days. What's the role of first trimester ultrasound scan in antenatal care? Like I said, generally, the goal of ultrasound scan is to provide information that we can work with so that we can achieve an optimized antenatal care to improve outcome in both the mother and the child. So these are the following rules. Number one, to localize pregnancy. And mind you, this is very, very important. Recent statistics shows that ectopic pregnancy accounts for up to 8.6% of maternal mortality. That's huge. That's approximately like 9 women in 100 of every woman that is pregnant. That is significant. To confirm and be able to localize pregnancy, either is intrauterine or extrauterine, very important. To confirm viability, and that's when we talk about a pregnancy that is ongoing or one that is failing. To be able to establish gestational age. Now, if there's anything, any singular thing that is important in antenatal care, is being able to accurately establish gestational age for our patients. Very important. Because with wrong dating, you could actually iatrogenically cause preterm delivery or even prolonged pregnancy. Gestational age is central, very key in managing a pregnant woman. And also to be able to determine the number of fetuses, and where we have multiple gestation, to be able to assess for chorionicity and amnionicity. It can also offer an opportunity to detect gross fetal abnormalities, but mind you, it's not a crux of first trimester scan. Gross malformation, most of them develop later in pregnancy, and even with the best of technique, you might not still be able to pick some of them. Okay, to detect signs of early pregnancy failure. And also, we're not going to talk about this, but just to mention it, first trimester aneuploidy screening. We have the nuclear translucency thickness together with other biochemical markers that improve sensitivity and specificity for picking some structural defect. And then basic anatomy after gestational age of 11 weeks. These are the following roles that first trimesters can play in antenatal care. Now, what's the right timing, and who should even be scanning? Who are the people that should be scanning in first trimester, or who are people that should be scanning pregnant women at all? It's advisable to offer the first scan between 10 and 13 weeks and 6 days. Now, why? To be able to achieve all the outlined role that I've talked about earlier on, it is better to scan between, most preferably between 10 and 13 weeks and 6 days. Now, for the personnel, I will talk more on that as we go on. For the personnel that are scanning, scans should be performed by individuals that have completed training, like we have started. You see, we are on the right path. And we have completed training the use of diagnostic, ultrasound, and related safety issues. Remember your ALARA principle, as low as reasonably achievable. Then such individual must participate in continuing medical education. See, it's not enough to just start with this training. For those in Sierra Leone, I know that after these, you're going to go on to your on-site training. It doesn't end there. See, the learning curve for ultrasound is very long. You have to keep scanning, you have to keep reading, you have to keep learning. That's the only way you can be good, and also be sure that you're scanning according to standard practice. And also, it's not just enough to scan, there must be established and appropriate care pathways when you have abnormal or suspicious findings. Now let's move to the guidelines in itself. Assessment of viability. Viability from ultrasound perspective is a term that is used for the presence of an embryo with cardiac activity as at the time that you are examining that woman. So viability means that you can see an embryo and there's a cardiac activity that is demonstrable at the time you're examining the patient. What are the early pregnancy measurements? So what measurements can we take in a first trimester scan? The first is gestational sac, and it is the first sonographic evidence of pregnancy. So I'm sure that we're already answering some of the questions we started with. Initially, it's round. If you can see my marker, you can see this is the gestational sac here, and it's round. It's very close to the fundus, and it's peripherally located, unlike a pseudo sac that can be centrally located. And this can be seen as early as 37 days post the last menstrual period, especially with high resolution transvaginal scan. And it even says that some embryonic cardiac activity can even be peaked as early as 37 days post the last menstrual period. Now, to take the measurement of the gestational sac, what you do is the mean sac diameter. So you take 3 measurements and then you take the average of them. Most of the machines automatically will just calculate this for you. But mind you, gestational sac shows a lot of variability in gestational age. Now you understand why the optimal time to actually do a first trimester scan is from 10 weeks, because gestational sac has been shown to show a lot of variability in relation to the actual gestational age, as opposed to crown rump length. I will still get there. So yolk sac is the first anatomical structure that is seen with the gestational sac. And you can see this is the gestational sac here, and this is the yolk sac. Remember yesterday we mentioned some terms, talk about hypoechoic, anechoic, and isoechoic. So I'll bring the terms in at this point. Now look at the yolk sac here. Inside of it is black. So that means it's echogenic. Sorry, it's anechoic rather. So it has an anechoic structure, and it has an echogenic periphery. You can see the outline, the rim is white. So that is echogenic. And when you have this yolk sac within the gestational sac at this point, instead of being spherical, becomes ellipsoid. Then the crown rump length provides a more accurate estimation of gestational age when compared to the gestational sac. And you can see the image here, and the calipers. See, this is the calipers. Is this is at the cephalic part, which is the crown, and then the other one is at the rostral end. So we measure the crown rump length. Now, to be able to get an accurate measurement of your crown rump length, there are techniques that you must achieve. Number one, the embryo should be in neutral position. That means that the fetus, the embryo should not be hypoflexed or hyperextended. Now, for early gestation, especially up to 9 weeks, fetus are usually, they assume an hyperflexed state. So when you take your crown rump length at that early gestation, books actually have it that what you're actually measuring is not crown rump length, it's neck rump length, because fetus actually, they assume an hyperflexed orientation up to 9 weeks. So you can see why the 10 weeks is most favorably opposed to when you're talking about early scan and gestational age assessment. Then you must not include other structures. For example, sometimes you can have your yolk sac that is still present around that time. Including the yolk sac, we wrongly give you a bigger gestational age. So the way to know if the embryo is in a neutral position is that you will see pockets of liquor between the chin. So this is the chin, and then the chest region. You can see this dark area. So that's fluid as the liquor. So when you have this, then you know that the baby, the embryo is in a neutral position, and you're good to apply your calipers and then get the crown rump length. So like I said, it provides a more accurate estimation of gestational age. Now, what are the diagnostic signs of early pregnancy failure in first trimester? Number one, we have a crown rump length that is at least 7 millimeters without cardiac activity. In essence, what I'm saying, when can you make a diagnosis that this pregnancy has failed and it's no more? So crown rump length that is at least 7 millimeters without a cardiac activity. Number two, when you have a mean sac diameter, that's in reference to gestational sac now, that is at least 25 millimeters without an embryo. These are signs of early pregnancy failure. When you have absence of embryo with heartbeat at least 2 weeks, after you've done a scan that showed a gestational sac without a yolk sac, or absence of embryo with heartbeat at least 11 days or more after you've done a scan that showed a gestational sac with a yolk sac. And the last is when you have an embryo, irrespective of what the crown rump length is, without cardiac activity on a repeat scan. That means you did a scan last week, seen the embryo, there's no cardiac activity. You tell the woman, okay, you come back in 1 to 2 weeks, you repeat the scan in a week time, there is still no cardiac activity. Then you're talking about early pregnancy failure here. Then remember, I said one of the role it plays in antenatal care is to be able to know the number of fetuses. It's very important to do this because it actually dictates the care, the individualized care you give to this woman in antenatal period. Okay, so we can see this higher order gestation. If you see this, like 1, 2, 3, 4, 5, 6, 7 here. And then when you come to this side, you have twin gestation. This twin gestation here, we have the dichorionic, and we have the monochorionic twin here. You know, I talk about it also helps to determine the chorionicity and the amnionicity in multiple gestation. Okay, you can see this symbol, this is the lambda symbol, and look at this region. This actually depict a dichorionic twin gestation, and this is similar to this. It's called the lambda sign or the twin peak sign. And this is actually formed by the fusion of the two placentae. So the fusion of the two placenta is what gives you this hipped up mass here that looks like the lambda sign. So it's actually called lambda or twin peak sign. Then we have the monochorionic twin, which is typified by the T sign. Assessment of gestational age. I've explained that severally, why we prefer it to be done between 10 and 13 weeks and 6 days. And it's based on the following assumption: that the structures we've measured are normal, the measurements are reliable, both within and between observers. I talk about the techniques to be able to achieve the crown rump length. We can't be taking the crown rump length in a wrong way and accept that gestational age. No, not right. Then your ultrasound machine should be calibrated correctly. Check your preset. Be sure that your machine is on first trimestral scan. And also for people that use the machine for non-obstetric purpose, ensure to change it to obstetric so it doesn't, because something can be on abdominal, then you're taking measurement, it will give you wrong things. Now, we can't finish this talk without talking about safety in first trimester. Fetal exposure time should be minimized using the shortest scan time and the lowest possible power output using our ALARA principle. We talked about this. And then we talk about, yesterday, I think this is like emphasizing it again, that the B mode and the M mode, because they generate lesser acoustic output, lesser energy output compared to Doppler scan, okay? So Doppler ultrasound scan is associated with greater energy output and therefore more potential bow effect. And so it should only be used in first trimester if clinically indicated. Remember one of those questions that I asked at the beginning. And routinely is not needed actually in first trimester, but instead, for example, if you want to screen for trisomy 21, doctor's venosus, tricuspid valve, Doppler interrogation, those one comes into effect in first trimester, but these are not routine things. So don't go opening up Doppler on early scanning when you're scanning a fetus in first trimester. So the take-home message is, please, recommendation is that all pregnant women be offered an early ultrasound scan between 10 and 13 completed weeks to achieve all the role that we talked about earlier on. And then it's recommended that crown rump length should be used to determine gestational age. However, once crown rump length is above 84 millimeters, please, you can't use this again. You have to move up to head circumference or in the first trimester. And in first trimester, head circumference is more precise than the biparietal diameter, because in biparietal diameter, there's some genetic influences. There's this dolichocephaly where you have and the fetal score in some people, some families, is a little bit elongated, okay? So in some cases it's physiological, there's no pathology involved, but because of that, you can have some inconsistencies if you use the BPD. So the head circumference is more reliable. That's if the crown rump length is more than 84 millimeters. So don't forget your ALARA principle. So we go back to the question. The first sonographic evidence of pregnancy, the person that answered the question was correct, is gestational sac. Then ALARA principle stands for as low as reasonably achievable. He was also correct. Nobody was able to answer this, so I would like someone to unmute and take the last question, please. What's the cutoff beyond which the crown rump length cannot be used in a first trimester scan? Please, can someone unmute and answer this last question? I'm wrapping up.
Yes, 84 millimeters.
Thank you very much. 84 millimeters. So once it's 84 millimeters, if it's still first trimester, what can you switch to? Which one can you use?
Head circumference.
Thank you very much. Thank you very much. Okay, so I've come to the end of my lecture. Thank you very much for listening. This is a painting that was rendered from an ultrasound image of an embryo. I hope you like it. Thank you very much. I'll stop sharing now so that we can take our questions and answers. So please, you can unmute and ask your questions, or if there's any clarifications, or if you don't want to do that, you can drop it in the chat box.